Dear Chairman, dear sirs and madams, I am Dr. Sebastiano Lava, Fellow of Pediatric Cardiology at University Children's Hospital of Lausanne. Thank you for the opportunity to present you our small series of 3 patients with a failing Fontan, characterized by 2 typical complications, namely protein-losing enteropathy and plastic bronchitis. Protein-losing enteropathy is characterized by hypoalbuminemia, edema, and elevated alpha-1 antitrypsin in stool, and it affects 10 to 20% of patients about 10 to 30 years after Fontan completion. Plastic bronchitis is characterized by the formation of bronchial casts, which obstruct the airways and that you can appreciate here in the picture. This consists of cross-linked mucin, small amounts of fibrin, and inflammatory cells like lymphocytes and eosinophils. Plastic bronchitis affects about 4% of Fontan patients. Both conditions are unfortunately characterized by high mortality of up to 50% in some series. The pathophysiology is to some extent shared. One has to remember that a Fontan physiology needs higher pressure in the systemic venous system than in the left atrium in order to passive lung circulation to work. With this in mind, both conditions appear to result from a combination of altered hemodynamics and increased systemic venous resistance, which might lead to an increased lymphatic pressure and in turn to dilated lymphatics, so-called lymphangiectasia, and formation of new lymphatic vessels and collaterals, so-called lymphangiogenicis. Between January 2019 and May 2020, we treated 3 male patients, one from Bern, one from Geneva, and one from ourselves, by means of a percutaneous lymphatic embolization. They range in age between 5 and 18 years and in weight between about 15 and 50 kilos. The protein-losing enteropathy patient was diagnosed by this condition 4 years after Fontan completion, and he underwent the percutaneous lymphangiography at the age of 18, it means 13 years after Fontan completion. The 2 plastic bronchitis patients were diagnosed 2 to 4 years after Fontan, and the procedure was performed 3 to 6 years after Fontan completion. One of these patients underwent 2 procedures 3 months apart. The second patient is also scheduled for a second procedure because of gas recurrence 10 months after the first one. So, the procedure is actually the following one. A needle is bilaterally inserted in the inguinal lymph nodes, you can see here on one side. And in the first step, a lymphangiography is performed by means of a water-soluble contrast medium. You can appreciate here in pink dilated lymphatics. In the second step, these dilated collaterals are embolized with a mixture of lipiodol and histocril. There were no relevant complications and all patients showed a marked symptomatic improvement. In conclusion, we presented here a pathophysiologically grounded, mechanism-based percutaneous intervention which causally addresses 2 of the major complications of Fontan circulation. This procedure is valuable and safe, and we presented here the first 3 pediatric cases in Switzerland. We feel that in severe cases of protein-losing enteropathy and plastic bronchitis, which do not satisfactorily respond to standard medical therapy, lymphatic embolization should be considered. I am unfortunately not available at the timeline assigned to me, but I will be very happy to answer any question via email. Thank you a lot for your attention.